My name is Jeff Miller. I'm the founder, Chief Scientific and Chief Executive Officer of Invivoscribe and the other companies. And we're really very pleased to have you here this morning. We have Dr. Maria Arcila, who's the Molecular Diagnostic Laboratory Director at Memorial Sloan Kettering.
My presentation today is primarily on the clinical utility of next-generation sequencing assays in establishing clonality and monitoring of lymphoproliferative disorders. These are assays that we have now validated for complete clinical use and that we perform routinely in our assessment of clonality testing and MRD in lymphoid malignancies. Now, clonality assessment by NGS methods provides marked advantages over amplicon-based methods because it allows the identification of a full range of clonal populations. It allows you to determine specific DNA sequences of clonal rearrangements. You can also detect clonal events that may be hidden in this polyclonal background. And you can track residual disease. Also, for B-cell malignancies, you can also examine somatic hypermutation at the same time, which is a prognostic marker for diseases like CLL, and we are starting to see it on hairy cell leukemias as well. But beyond the clonal detection, you may also identify both stable and dynamic aspects of the immune repertoire that differ under normal and disease conditions. So you're getting so much more information. It also provides a very high-resolution picture of the spectrum of immunity that is found in lymphoid malignancies, and it allows you to define initial behaviors of clonal tumor populations, suppression or reemergence of these populations following treatment. So I'm just going to walk you through some of the details of the assay. For the IGH and somatic hypermutation assay, this is the design. What you have is primers that target specifically the FR1 region in here. And also for the somatic hypermutation assay, you have the addition of the leader primers, which allows you for better performance of the assay under these conditions. You also have the J primers, as you can see here. For the T-cell receptor gamma G rearrangement assay, you're targeting these regions of the V gamma family that you see here. Now, what I want to go over in the next few minutes is our experience with the assay, how we validated and how we implemented this assay. So I come from New York, and by New York State standards, and to be able to get an assay through New York State, we have to go through very, very stringent way of validating the assay. So our validation for the characterization assay was pretty extensive. We took 67 samples. We decided to go with a very wide distribution of samples. So most of the samples that we get for clonality assessment are going to be bone marrow aspirates or bloods. But we also get a significant amount of paraffin-embedded tissue, which we included here, and maybe a lower volume of body fluids, which you can also assess with this assay. We did our baseline screening using Biomed 2 primers, a PCR-based capillary electrophoresis assay. And then after screening the samples, we did the NGS clonality testing for IGH and TCR gamma, which was all sequenced on an Illumina MiSeq. This is the summary of the validation for the 67 samples. And as you can see, there is a very, very good correlation between the CE assay and the LymphoTrack. So the samples we had for IGH, we had 11 samples total that were clonal. 10 of them were clonal with the LymphoTrack assay out of the 11. And these that you see here that are the outliers were actually the only two discordant cases, this one for TCR gamma, this one for IGH. And the discordant cases were cases where you actually had the NGS assay resolving clonality calls where we made a call of clonality that was actually a pseudoclone. So we were able to resolve some of those calls with this new assay because it gives you so much more information for each individual clone that you have, and also the usage. In terms of how the assay, how the reproducibility of the assay works, this is an example of our IGH reproducibility study. When you run the assay, both inter and intra-assay reproducibility are very tight, as you can see here. However, you can see difference from run to run up to 6% between the runs. But even these are samples that we run in 3 different MiSeqs. And even then, when you look at the distribution of the primary clones, they're very, very close together. Now, in terms of sensitivity, we did 2 different sensitivity studies. One of them, which would be your sensitivity for a primary diagnosis of clonality. So one where you would see the clone, to be able to make the call of clonality, you would have to see that clone rise above every other clone that you have in here and be a prominent clone. So we wanted to show that our sensitivity for the assay was close to the fragment analysis assay, but that it could also go beyond that, the 5% that we usually quote for the CE assays, and we wanted to see that we could call this at 1%. So you can see here that the R values are very good. So in terms of sensitivity, we can call a clone down to 1% in both the IGH and the TCR gamma assays. I want to show you some of the plots on how the sensitivity studies look like. So here, for example, this is an IGH. The IGH sensitivity, you can see here at 10%. It's very easy to call this a clone, even though you start seeing this polyclonal background. Now, if you had a CE assay, when you start seeing this polyclonal background, you're relying on the height of the clone. And here, you can just easily see the sequence of the clone. And even at 1%, where a call by the CE method, you would not be able to call this clonal because your polyclonal background is just as high as the height of the clonal peak. In this case, it's very easy for you to say, oh yes, this is a clone. So any clone that may be hidden in that polyclonal background is much more easy to see here, along with the information on what the sequence of the clone would be. Now, for primary samples, your interpretation rules are different to what the MRD or the minimal residual disease rules are. So these are our interpretation rules for a primary sample. So we don't usually call anything with this assay if we don't have more than 20,000 reads. And what we usually do is we'll look at the top 10 sequences, and if they have identical VJ gene rearrangement and also less than 2 bases differences for the size of the sequences, we add those together to give you the percentage of that top clone. So if the reads, if 1 or 2 reads are more than 2.5% and they happen to be more than 2 times the 4th most frequent unique sequence, then we can clearly say that there is evidence of clonality. However, if the top read is 2.5%, but is not very much different from the 4th sequence, then you cannot say that there is evidence of clonality. And also, if all the reads are less than 2.5%, you cannot call clonality on a primary sample. For the MRD level, for minimal residual disease, the rules are completely different. You're not relying on the percent of the clone. What you're actually looking is for a specific clonal sequence, and you can go as far as 0.00001%. So you can find a sequence, as you can see here from our sensitivity study. You could, but this is done on a cell line. You can find a sequence, even if you go as low as this 0.0001%. But this all depends on how much input DNA you have. So if your input is low and it doesn't give you that many reads, then obviously you're not going to get to the sensitivity. So this is all dependent on how much DNA you have on the sample. So for us, we go very conservatively. Even though we have shown that we can go this low, we don't usually say that we can go beyond 1 in 100,000, and we would require to find at least 5 reads to be able to say that we have found minimal residual disease. So how did we get from the validation of the assay to clinical application? And I figured that it would be easier to go through some of the clinical samples that we see every day in our laboratory. Just that to make it a little bit more interesting and maybe a little bit more relevant. So here, for example, is one of the cases that we have seen this year. This is case number 1, and it's a lymph node biopsy from paraffin-embedded tissue. And this biopsy is from a 57-year-old female who had a history of CLL, SLL, and came to the clinic with an enlarged right axillary lymph node with 70% diffuse large B-cell lymphoma. And the question was, is this a transformation from an original CLL? It did have a CLL in the background, which was about 30%. There was unfortunately no prior clonality testing in-house for us to be able to compare. However, we did have from the chart review that this patient had an original somatic hypermutation status done, and we knew that the sequence that we were looking for was this family V459. This patient happened to have a productive clone that then had an unmutated status. So as you can see here from the fragment analysis, right now we're running everything side by side, at least for the first few months since we instituted the assay, just to give us familiarity on how they look in comparison to the assay that we have used for several years. So in this case, you can see this has two different clones in here. And this is how the LymphoTrack study would look like. So again, you can find the two clones. These are the two top clones, and one of them is 36%, the other one is 28%. You can see the distribution very easily here, so two very prominent peaks with completely different usage, and then you can click on each individual one of these sequences to see the entire sequence and be able to track it later on in the disease. So one of these clones did happen to be the V459, which is the second one, but we had, in addition to the one that was previously reported, the one on the top, which was the V348. This is case number 3. This is a 71-year-old female, former smoker with history of lung adenocarcinoma. This patient was being followed radiographically for several years with multiple right-sided nodular ground glass opacities. And it just happened that in 2011 had this very slight increase in size of one of the middle lobe lesions. So an FNA was done and a needle biopsy was performed at the same time. And this is how the needle biopsy looks like. This was a very difficult sample for us to diagnose because the patient had a diagnosis of carcinoma. So we were looking for carcinoma, but in addition to the few glands of cancer that this patient had here, there was also a very intense lymphoid infiltrate around the malignancy, and this was the only area where the lymphoid infiltrate was seen. So the question was, is this something that is reacting to the tumor, or is this an actual marginal zone lymphoma in the lung? So we decided to do both the testing that you would do for a nanocarcinoma, so we did EGFR, KRAS testing, but then we also did the LymphoTrack assay and the fragment analysis assay. But you can see here, this is a closer view of the lymphoid infiltrate, and this is the wedge resection of the same sample. Making a diagnosis of lymphoma and carcinoma in a needle biopsy is something that I myself as a pathologist wouldn't like to do. So we did ask for more tissue, and we confirmed that in fact this patient had two different processes going on. The lung adenocarcinoma happened to be a KRAS mutated lung cancer with a G12V mutation that you can see here. But in addition to that, had the clonality testing. So this patient had a clonal peak that you can see here, maybe a minor one in here. And here is the LymphoTrack assay where you can actually track the clone. This patient happened to have multiple lesions. All of them were KRAS mutated, and every single one of the lesions that this patient had that were resected by wedge resections had exactly these same clones. So very interesting case and very difficult to diagnose without the clonality testing itself. So the diagnosis for this case was a synchronous multifocal lung adenocarcinoma and a primary lung extranodal marginal zone lymphoma. Now, how do we do our MRD assessment? This is one example of our MRD studies. This is from a 57-year-old male with a growing subcutaneous nodule in the arm, which was diagnosed as an atypical T-cell proliferation, most consistent with an angioimmunoblastic T-cell lymphoma. In addition to having this angioimmunoblastic T-cell lymphoma, the patient also had this very dense lymphoplasmacytic infiltrate that was associated with the lesion, and this patient also had a history of Waldenstrom's macroglobulinemia. We did have the clonality testing of the Waldenströms before, so we wanted to compare what this looked like. So we did both the IgH and TCR gamma rearrangement studies on this patient, and this is how they look like by fragment analysis. So this is the subcutaneous nodule with the angioimmunoblastic T-cell lymphoma, where you have a polyclonal background and then 2 prominent peaks, so this was positive for clonality. And this is the extensive lymphoplasmacytic infiltrate. This is the IgH study, where you can see 2 definite clones. This is how the LymphoTrack assay looks like. You can clearly see that there are 2 prominent clones in here. One of them is 14%, the other one is 7%, so more than the 2.5% that we use for our cutoff, and then the sequence of the top clone. We followed this patient along for not only the original bone marrow biopsy that was done for staging, but also post-chemotherapy, pre-transplant, and also post-transplant. So these cases are, as you can see, very difficult to track or to know if the patient has residual disease, because a lot of times when you start with a polyclonal background in the diagnostic lesion, most likely everything else is going to have a higher polyclonal background, and calling clonality in this case is extremely difficult by the fragment assay, as you can see here. So we do have here a hint that this may be the 2 same clones that you have here, but as far as being able to call it, especially when you have a completely negative biopsy by morphology, you always want to hedge and say, well, maybe there is some residual disease, but I am not quite sure. With the LymphoTrack assay, this becomes very easy because you can actually see the clones in here and you can track the specific sequence. So in this case, this patient did have exactly the same 2 sequences, as you can see here. And even in this post-chemotherapy pre-transplant, you see a lot of oligoclonality with many prominent clones, I would say. But again, the same exact sequence can be seen much lower than the other ones that you're seeing here, but you can still track it and know that the disease is there. So the study that we did on this patient was to follow several, the 2 clones, and even some of those other clones that you saw post-chemo, just to see what they would do. Now, sometimes it is very difficult for patients when you're tracking these clones while they are actively receiving therapy. You may have differences in 1 or 2 bases and maybe 3 bases, which is the effect of the chemotherapy. And you can see this arrangement in here. This is actually exactly the same clone. You can see it here, 123 base pairs, but in none of them is actually more than 2.5%. So you actually have to go and look very closely at these sequences and see how different they are and if they actually do belong to the same original clone, but it's just that you have a little bit of mutation associated with the therapy itself. But for this case, clearly you have the 2 clones are present. And when you do the analysis of that pre-transplant sample, you can go and look for that specific clone. Now, as I said before, your sensitivity of the assay depends fully of how much DNA you can actually add to that assay. So in this case, we wanted to go very, very deep, and we ended up running the sample 5 different times, and you can see here the number of total reads that you get for each individual one of those. In every single one of the runs, these constitute independent tubes, independent reactions. You can see that the total number of reads for this larger clone, which we're tracking right here, is about 0.7%. So we were able to say in this case that this patient did have residual disease before transplant, and they would have to go for additional therapy before they can actually transplant this patient, but this is not something that you would be able to tell by the fragment analysis assay alone. Now, for another case, this one is case number 4, is a 68-year-old male with increasing lymphocytosis since 2011. Patient had adult T-cell lymphoma, leukemia, and right here is the fragment analysis of the original TCR gamma clone. By next-gen sequencing, you can now characterize the clone, and you can track this specific sequence across the different samples that you get later on. And for this specific patient, This was, by fragment analysis, probably one of the most difficult cases that I have seen, just because post-transplant, you can get this oligoclonality that you see here. So you see a clone that is completely different to the original clone. So this is something that if it is not in the same position, I would say this is probably a pseudoclone. But that was not the case for this clone over here, even though it's much lower. It aligns exactly with the prior clone, so I just really didn't know what to call this, whether this patient actually had residual disease post-transplant or not. But the call of a pseudoclone or residual disease or recurrent disease is very easy with the LymphoTrack assay. We just go back to all of the sequences that you're getting, and for this, we could not find the sequence anywhere in any of the runs that we did. So this patient was free of disease, and we were able to say this was a pseudoclone. This patient doesn't have any disease. The patient is still okay with the transplant that he has. Now, case number 5 is a 49-year-old male with a right parotid lesion, which was diagnosed originally as a peripheral T-cell lymphoma, not otherwise specified. Now, this patient had, by the LymphoTrack assay, the parotid lesion had 2 completely different clones in here, which is not something that you see in here. But what you can actually notice in here is that even though you have clones that are exactly the same length, you can see it here is 111 base pairs. These are actually 2 completely independent clones with different sequences that you can see here. So while the fragment analysis assay will tell you that the patient only has 1 clone, you can characterize it fully, and you will know that it is actually 2 different clones that you would need to track in this patient's disease. Very briefly, on my last 2 slides, we're also using the assay for somatic hypermutation. So every single sample, regardless of whether it is a CLL or not, we do the somatic hypermutation. This is how the somatic hypermutation assay looks like with the LymphoTrack assay. In this case, you're getting the same output as you would get for the IGH, but it also gives you the assessment of the somatic hypermutation. So you look at basically how much identity you have on that sequence compared to the germline sequence. In this case, is 93%, so about 7%, which would be more than the 2% that is expected for you to be able to call somatic hypermutation. So this is a hypermutated case, which also happens to have this V434 usage, which is associated with a very indolent behavior for CLL. On the other hand, you have this case that is not mutated. It's a 100% sequence identity with germline. And this also happens to have a 321 usage, which is associated with very aggressive disease, which is independent of the IGHV mutation status. So in conclusion, we're very happy with the assay and having transitioned to next generation sequencing. The assay very efficiently detects IGH and TCR gamma gene rearrangements using a single multiplex master mix. The results are highly concordant when compared to the fragment analysis and the Sanger sequencing that we were doing before. However, doing Sanger sequencing and cloning for you to be able to characterize these clones is very time-consuming, and now is a very seamless process that you can do in just a few days, and you can do it in all the samples. It concurrently identifies the sequence information required to track the clones in subsequent samples, and we have been able to show that we can get to MRD levels that are about 1 × 10⁻⁶, but then again, this is fully dependent on how much input you have. So very easy for bone marrow biopsies, very easy for blood samples, but not so easy for skin biopsies or very small biopsies, which is a lot of what we get sometimes. The somatic hypermutation analysis is very simple and highly concurrent with the CE and Sanger assays that we were using before.